Hello, everyone. Welcome back. My name is Dr. Reshma Matani. I'm an associate professor of medicine, a breast medical oncologist at the Sylvester Cancer Center, University of Miami, where I co-lead our breast cancer program. I'm pleased to have with me an esteemed panel of faculty from various institutions, and we'll be having a panel discussion, clinical conversations in breast cancer. Today, we're focusing on actual questions that we wish patients would ask us instead of the other way around. So I think this is going to be a great conversation. Mediget, I'll ask you to start by introducing yourself and where you practice, what you do.
Hi, everyone. I'm Mediget Teshome. I'm a breast surgical oncologist. I'm practicing at MD Anderson Cancer Center here in Houston, Texas.
Thank you. Stephanie.
I'm Dr. Stephanie Graff. I'm a breast medical oncologist at Brown University and the Lifespan Cancer Institute in Providence, Rhode Island.
Wonderful to have you with us. And Kristina.
And I'm Dr. Kristina Mirabeau Beale. I'm a board certified radiation oncologist practicing with Genesis Care USA, based in Fort Myers, Florida, and at our regional cancer center in Fort Myers.
Thank you. Thank you all for being here today. I know that like many of you, I see very often that breast cancer patients are very astute. They ask wonderful questions. They're very educated. I think as women, we tend to take things into our own hands when we're faced with any adversity, and a breast cancer diagnosis is no exception. However, although patients come to us many times with a list of questions, we're very organized as women. I think sometimes there are questions that should be on that list that maybe sometimes are not. So here's an opportunity to kind of look under the hood, so to speak, and hear from experts in terms of questions that we wish you would ask us. So I'm going to start by asking Kristina a question that I think as physicians, we really often wish that patients paid more attention to or bought more into, which is lifestyle modification. So here's one: what lifestyle modifications can I make during radiation therapy so side effects are more manageable?
So, especially as you meet a patient, you kind of establish kind of what their support systems are and their existing habits. I always kind of normalize that, they're about to begin a journey. And so it's important to kind of give themselves grace. It's very important to do things like, be mindful of exercise and activity, eating a balanced diet, plant-based, all that good stuff. But at the same time, if you need to eat a Chick-fil-A milkshake because you're feeling really sick after treatment, that's okay. Also kind of rallying one's support systems. At our cancer center, we fortunately have social workers and therapists in massage therapy and acupuncture and a lot of complementary therapies that patients can sometimes try it for the first time during their cancer journey, as they try to, help their bodies as well as their minds during treatment. And then also setting kind of the expectation of how symptoms unfold. So with radiation, at least, the side effect profile in terms of skin reaction, for example, tends to kind of be cumulative and happen in a somewhat predictable fashion. So we see our patients weekly and then usually kind of hold their hands through things as they intensify so they know what to expect, and then offer a lot of samples of different skin creams, for example, and things so that they can also have some suggestions for different products that they can use to kind of help with the skin reactions. So from a lifestyle perspective, I think, general kind of healthy principles, and then also kind of managing expectations and making sure there are additional resources available for them to try new interesting habits that may be helpful for them.
Great. Thank you for that. So one thing that I think comes up quite a bit in terms of patients and how they perceive our treatments, oftentimes patients equate efficacy equate toxicity with efficacy. So when they think of getting an aggressive treatment for their cancer, they think perhaps that they went through chemotherapy and they lost their hair and they were susceptible to infection and they went through the hard work of that. But as medical oncologists, we know that oftentimes the hard work even comes after the chemotherapy, and that's the endocrine therapy. So Stephanie, talk to me about how you broach this topic. I find in my practice, patients, when they're first diagnosed, they tend to ask a lot more questions about the chemo and tend to think of the hormonal therapy as just a pill that I'll have to take. And then when the side effects hit, they sometimes are really struggling, and sometimes struggling silently. So what do you wish that they would ask you?
Yeah, Wow. There's the endocrine therapy that we prescribe, whether it's tamoxifen for a premenopausal woman or an aromatase inhibitor like Arimidex or anastrozole, letrozole, Femara, Aromasin, exemestane for postmenopausal women or premenopausal women with ovarian suppression. Those medicines come with a lot of side effects. And I think the sort of word on the street is that if you have a hormone receptor positive breast cancer and don't need chemotherapy, that you have quote unquote good cancer, and that, because you don't need chemotherapy, everything's wonderful. Or even in the situation where if you have hormone receptor positive breast cancer and receive chemotherapy, that once the chemotherapy is over and you're on the endocrine therapy, that it's going to be a cakewalk. And the endocrine therapy does come with a lot of side effects. It can cause joint stiffness or muscle aches and pains that can be pretty dramatic. Patients can have pretty significant hot flashes. Certainly, patients can notice mood changes, changes in their sexual health or intimacy. And those can all be subjects that patients either don't bring up or don't suffer silently with, or worse yet, they'll discontinue treatment without talking to their medical oncologist about it, or minimize the value of what endocrine therapy means for their long-term cure and survival of their cancer. And so I guess what I want patients to know is that endocrine therapy is cancer treatment, and it's really important cancer treatment. And there are clear interventions that we can take to mitigate the side effects of those medicines. And the sooner you bring it up and talk to us about it, the more effective that those interventions are going to be. So if you're having symptoms and side effects, make sure that you talk to your medical oncologist. If you feel like your medical oncologist isn't listening, it's a reason to get a second opinion, just as important as when you're talking about chemo or surgery or radiation. It's a big deal. Make sure you're being heard.
That's such a wonderful point you made. I really can't emphasize that enough. I think that, for many of us who are busy taking care of patients, and the patients that are on endocrine therapy for the 6-month follow-up, it's supposed to be the quick visit. Sometimes it's not the quick visit, and we need to stop and give the time that these women need to discussing these really important issues that, for example, you brought up, including sexual side effects, which are really difficult to bring up. And so I think that for us as providers, we need to be proactive in bringing up these issues with patients so that they don't necessarily feel the burden of that. So Mediget, from the standpoint of surgery and questions that you wish that patients would ask you, the long-term side effects or impacts of surgery, many questions ask about the acute side effects, and it's intuitive, to go through a surgical procedure, what that means. But I don't think necessarily they think through all of the long-term side effects. So talk to me about that and how you would approach those questions if asked.
Yeah, thank you so much. Along the same lines of what you were just discussing, one important thing that I always like to mention to patients, especially those who are considering, doing what we call contralateral prophylactic mastectomy or bilateral mastectomy, removing a normal breast, is that this can, and I have seen with other patients, really impact in some women their body image, or even their sexuality and other aspects in their life that really add to their quality of life. So when we think about surgery and when we counsel women about surgery, we also want them to, of course, we focus on cancer. That's the number one, and getting the best oncologic outcome. But also, how can we, support them to live, a long, healthy, fulfilled life? So we do take into account these things. That's why we talk about oncoplastic reconstruction, plastic surgery reconstruction. Why we talk about minimizing, surgery that may not be, needed. So those are some things I think that I would like to make sure that patients know. And then, as we've discussed earlier, the side effects such as lymphedema and how can we reduce those risks are also really important as well.
Mm-hmm. Really important points you brought up. So Kristina, I find that sometimes patients feel that what you do is sort of a black box. They really don't understand this whole concept of radiation therapy. They think you're a radiologist. They don't necessarily have a great understanding what you do down there in that room that you're in and where all those fancy machines are. So on the other hand, sometimes we have really sophisticated patients who are asking questions like, should I take proton therapy instead? So what are the types of questions that you wish patients would ask you as a radiation oncologist in terms of protons, IMRT, and all of the different fancy techniques that you have out there? Do you get these questions? And if not, what are you hoping that they would ask you?
We get them a lot because we're kind of, there's a lot of technology involved in radiation oncology, and there's a lot of toys, so to speak. And when I try to, take a step back, what is the importance or role of radiation kind of in that patient's cancer journey? Normally we're there to kind of increase local control. And to the extent that, a lot of these different machines and technologies are able to kind of in more sophisticated ways deliver a dose more safely to minimize side effects. Otherwise, IMRT versus 3D conformal, sometimes image guidance, a lot of that has to do with just descriptors in terms of how more modern our techniques have gotten to be more precise in our target localization. But one technique versus the other isn't necessarily better killing their cancer. A lot of it sometimes has to do with patient geometry, for example, their breast or chest wall size, proximity to the heart, that sort of thing. A major difference is with protons, because it's a charged particle, just the dose fall off. There tends to be a lot of less integral dose. There's ongoing studies that are kind of looking at benefit of proton therapy, especially in like the post-mastectomy setting for left chest wall disease, to try to minimize heart dose. But on the flip side, even with standard photon-based radiation, through things like deep inspiration breath hold or treating patients in the prone position, we're similarly able to kind of optimize a patient's geometry so that the treatment's safe and we're minimizing excess radiation to normal structures. So, I tend to be very visual with my patients and sometimes going to draw like a cross section of what their breast looks like relative to their heart. And so what our goals are, and then also a patient's like breast size and shape factors into it. But to a certain extent, sometimes when we have patients who ask about certain trademark names or brands, I liken it to different cars. There's Tesla, there's your BMW, your Mercedes. Some of these have slight differences in their GPS systems, but ultimately it's really the driver who's going to get you where you need to go. And so you don't necessarily need to shop for like the newest machine as much as it is somebody who's current and kind of working within a multidisciplinary team and can, in an accessible way, explain to you what they're doing and why.
I love all these analogies we're coming up with. I feel like I should write some of them down to take home with me. They're really very helpful. And I think that they're very succinct in explaining to patients, the essence of the decision making, and they really are helpful. So one thing that comes up quite a bit for patients with cancer in general is this concept of 5 years. And Stephanie, you and I were talking about this briefly before the session started. How do you handle this discussion on the 5-year mark? Do you bring it up at all? Do you wish that people brought it up to you?
I don't normally bring up the 5-year mark unless patients bring it up. So to sort of say that back in a different way, a lot of our clinical trials in oncology use a surrogate endpoint of 5-year overall survival. And the reason that we use 5-year overall survival is that in order to report an endpoint, we have to draw a line in the sand. We can't use overall survival like forever and ever, amen, because then we would never move science forward. If we waited everybody to die of natural causes when they're 107, we would still be waiting to approve tamoxifen from 1974. So we have to slice the data and report it, and we do that at 5 years. And so when we talk about 5 years survival, it's not that at 5 years and 1 day, everybody dies, or at 5 years and 1 day, everybody's magically cured. It's that that's where we drew the line in the sand. And so there's nothing free and clear about 5 years. And so when patients bring it up or when we talk about it, I try to contextualize it in the concept of their disease. In triple negative and HER2 amplified breast cancer, they are more biologically aggressive breast cancers. And when they come back, they do tend to recur within that 5-year time frame. With hormone receptor positive breast cancer, unfortunately, the curve keeps climbing, and there's a risk of recurrence that goes on to 20 years and beyond. In the last year or so, there was an update in the New England Journal of Medicine that looked at 20-year risk of recurrence, and it was honestly, even to me as a breast medical oncologist, startling to see a curve that just goes like this. And so sometimes when I talk about that risk of recurrence, sometimes I'm talking about it in the concept of the 21 gene recurrence score, the Oncotype DX, that's the generic name and brand name of the same product, which is a 9-year recurrence score now is what's printed on somebody's paper. Sometimes somebody's bringing something that they read on the internet that's talking about 5-year survival, and they want to know what the magic about 5 years is. Sometimes we're having the conversation about whether we're going to stop their endocrine therapy at 5 years or extend it, because now there's evidence that taking it for longer is probably better. Is longer better for everyone? Well, that's a conversation we need to have. And so, you know, we just kind of get into the details and figure out what's right for each person and make sure that they can wrap their head around all of these numbers and curves.
Yeah, individualizing therapy, having patients involved in the decisions. I think those are all really valuable points. One question that I think that all of us who are really trying to, as you pointed out, move the field forward, many of us are very motivated to offer patients clinical trials. And I noticed that as we were trying to get together this list of questions, many of us brought up this issue of clinical trials. Are you all getting a lot of patients asking you? I noticed that this question ended up on the I wish patients would ask me list instead of the these are the things patients ask me. So how do you all handle the questions that patients have on studies, especially with regards to feeling that they're being experimented on, or this guinea pig question that comes up quite a bit? Any tricks there in terms of how you're handling those conversations about participating on a trial, Mediget?
Sure. Yes, I really do believe, and what I tell patients is that really the only reason we know anything about how to treat breast cancer at this moment is from clinical trials that have really moved us forward to be able to allow us to understand more about breast cancer, about individualizing treatment, and about tailoring treatment to their specific disease. So I do frame it in that context, and then I do also think that clinical trials oftentimes can offer an opportunity to patients to in a variety of ways. So I think it is one option in their treatment. So that's kind of how I try to present it. I don't want to go into too many specifics, but here's option, let's say breast conserving surgery, mastectomy, clinical trial, so try to, it is really an option. So I do think it's important, but I also think it's important for patients to understand that if they decide not to participate in a clinical trial, we'll still treat them with our standard of care therapy. And, and that's also their choice as well. So I do think it's really important though. And I think it's something that, without being asked, patients may not approach that subject.
Mm-hmm. Yeah.
I think in a world where most patients really love the idea of a multidisciplinary team participating in their care. And in my experience, most patients, second opinions seem really common in breast cancer. A clinical trial is the penultimate second opinion / multidisciplinary care. I mean, most breast oncology clinical trials are designed by an international team of the world's leading experts that lead the steering committee. And then there's an external review advisory board that's overseeing all the data. And then there is a national IRB, which is the ethics and safety monitoring team that makes sure that it's justice and safety and fair and balanced for the patients. And then there's the local team that comes along with the trial. So instead of just the doctor treating you and the doctor's normal infusion nurse and clinic nurse, you also get the clinical trial nurse and the clinical data team that's overseeing every single aspect of your chart. So it like quadruple, pentuples, I don't even know what that word is, for the number of people involved in your care. And who wouldn't want that? It's amazing. And there's very few scenarios in cancer care, especially in breast cancer, where the control arm, I mean, the control arm is almost always our standard of care, and the experimental arm is something we think is better, or we wouldn't be doing it. And I would sign up for a trial any day of the week and twice on Tuesday.
That's great. Thank you for providing that overview of all of the people that are involved, and recognizing that clinical trials are very carefully conducted and safely conducted in a way where the best interests of the patient is really put forward first. Kristina, anything you want to comment on in terms of radiation trials, things that you wish patients had asked or are asking you with regards to radiation studies?
You've accidentally muted.
I think you're on mute.
Now I'm off. Don't know what happened. So similar themes to kind of what's already been brought up, but then there's a whole generation of kind of deintensification trials in radiation. So it's kind of like the standard or something less. And I usually frame that as it's because, you know, we have these historical data and series that kind of show that, you know, you're in a sufficiently favorable population of patient, you know, where we think that we can safely deintensify treatment, whether it's with hypofractionation in a shorter course or even omission of radiation, because you have this you're in this carefully selected population of favorable biology, small disease, et cetera. That, and then also you're still going to be followed very closely. So, you know, within the framework of being on a clinical trial, you know, you're still going to be followed closely with physical exams, routine imaging. So even if there's less treatment in a radiation standpoint, and you have to kind of give up ownership of that decision making, you're still followed closely as a patient and still receiving, you know, usually your anti-endocrine therapy and, you know, being seen by all of your other doctors. So you're not kind of kicked out of the treatment team and not being followed as closely. And then also that a lot of the, you know, just kind of like was said earlier, we know what we know now because of the trials of the past. You know, won't know if we're over treating you in this situation unless we are able to conduct thoughtful trials that show we can safely deintensify our treatment. So it is important to kind of push the progress of the field forward.
Absolutely. So thank you all for your great insights this afternoon in our conversations regarding questions that we wish patients would ask us. And I'm grateful for your time and your expertise, and to all of those tuning in. There are a lot of reliable, wonderful resources out there for you as you go through this breast cancer journey. We hope that this adds to the list, and hoping to see you all in person in Florida next year, the pandemic permitting. Until then, please stay safe. Thank you for tuning in.